I'm Dr. Prashad Goda, Secretary NNF Karnataka State Chapter. I would like to welcome all of you again for this continued academic session, which we have been doing from last 2 months. Today we have been, past 1 week, it has been a beautiful journey in neonatal respiratory chapter, where we have discussed the basic to advanced issues and modes of management in neonatal respiratory chapter. So continuing the same thing, so today we have high frequency ventilation, acute deterioration, bedside management, and the nursing care, and algorithmic approach of uses of nitric oxide, where to use, when to use, how much to use, and what are the complications associated with it, what are the benefits associated with it, what are the do's and don'ts while we are handling baby on nitric oxide, inhaled nitric oxide. So we have got two wonderful speakers today, Dr. SUNIL KISHORE from Andhra, Vizag. Welcome to you, sir. On behalf of the State Chapter, we would like to give a warm welcome. And we have Dr. LESLI. Sir, welcome to you as well, sir.
Yeah, thank you very much.
And today's session will be moderated by Dr. Abhishek Phadke from Bangalore. Dr. Abhishek, so I request you to introduce the speaker, and I request Dr. SUNIL KISHORE to start the session first, followed by his session. Dr. LESLI will start, and the discussion part will happen. So I request all the participants to mute. Anyway, we are muted on you enter the session. I would like to request you to stop the video as well, so that there is no disturbance and the clarity is not affected. So if you have any issues, you can always message in a chat box. Any doubts, queries regarding the topic, please drop in the question in the chat box. So over to you, Dr. Abhishek.
Yeah, good evening. Welcome you all for the NNFK webinar series on these two very important topics on high frequency ventilation and inhaled nitric oxide. So the first session is going to be taken by Dr. SUNIL KISHORE. He is a consultant neonatologist from Medicover Hospital in Vizag. He has done his DA in neonatology from EJ Chandigarh. He has numerous publications, both national as well as international publications, journals, and he has a good experience in on high frequency ventilation as well as advanced neonatology. So welcome Dr. SUNIL KISHORE to the NNF webinar, and over to you, Dr. Sai.
Thank you very much, Dr. Abhishek, for that kind introduction. My voice is audible? Is it clear?
Yeah, you're audible. You're audible. Go ahead, please.
Friends, very good evening. I'm Dr. SUNIL KISHORE, neonatologist from Visakhapatnam, Andhra. And it's indeed my pleasure to interact with you all today here in this special platform. And I thank Dr. Dinakar, Dr. Prashant, and team for giving me this wonderful opportunity to interact with you all on high frequency ventilation. So, so far actually you had series of lectures on high frequency, almost 5 lectures. The first one was on the basics of high frequency, and the second and third one were basically high frequency in recruitable lung and high frequency in non-recruitable lung. In fourth and fifth, you had wonderful lectures on Sunday. So non-invasive high frequency by Dr. Dinakar, and one more volume guarantee, HFE with volume guarantee also. So, and I hope actually you have imbibed so much of knowledge on high frequency, and today's session is going to be very practical. So what you are going to do at the bedside of the baby. So that's what we are going to discuss in today's session. So bedside, what you need to do, and if any acute deterioration happens, so what is your job, and whenever you are doing any procedures, so how to apply high frequency. So basically bedside application. So how to set up the ventilator, and how to set up the circuit. So how to recruit the lung. So how to go about further, and how to monitor these babies on high frequency. What is the role of the nurse, and what is the role of doctor, as well as your in-house registrars, and what are the orders you need to give to nurses as well as doctors. So that's what we are going to listen. And if there is any acute deterioration, so what should be done? And if you are doing any procedures like giving surfactant, and you need an echo, or a baby with CDH goes for a surgery, So how to apply high frequency during these procedures. So these are the things which we are going to learn in today's session. So overall, like if I have to discuss the characters of high frequency ventilation in a single slide, so this is what it is. So you have a frequency which is very high, so more than 2 hertz. So usually 5 to 15, which corresponds to 300 to 900 breaths per minute. And in high frequency, the inspiration as well as expiration are active. And usually you are operating at tidal volumes less than anatomical dead space. So normally when you talk of conventional ventilation, you talk of tidal volumes of 6 to 9 ml per kilo. Whereas in high frequency ventilation, your tidal volumes are much less. So you are talking of 2.5 ml per kg or 1.5 ml per kg in case of high frequency ventilation. So basically what you are doing is, you in high frequency, you are using a descending pressure. You are using a mean airway pressure to recruit the lung. And on the top of that, there are gentle oscillations to generate tidal volume. So that's what you are doing in high frequency. So what are the ventilators which are available in India to provide high frequency ventilation? So VN 500 from Drager. You have SLE 6000 and SLE 5000. Sophie by Stephen. You have Accutronics Fabian ventilator from Accutronics. You have SLE 5000 and Sensor Medics. So these are the ventilators which are available in India currently to provide high frequency ventilation. So what are the scenarios where you consider high frequency? So just to have a glimpse of the indications and how to go about. So basically whenever you think of starting high frequency, it is basically for two issues. So either it is difficult to oxygenate the baby. Baby is having stiff lungs or abnormal lungs, and it is difficult to oxygenate, and you are failing on conventional ventilation. You are crossing a safe limit of conventional ventilation, or to reduce the ventilation-induced lung injury. That means like where you are using primary mode. So the first one we call it as rescue mode. The second one we call it as primary mode of high frequency. So to begin with itself, you are starting high frequency to reduce ventilation-induced lung injury. So high frequency is considered to be one of the safe ventilation, because here the dynamic strain is less. So when you talk of VILI, there are two main things actually which are causing lung damage. One is static strain, other one is dynamic strain. And the dynamic strain is the one actually which causes more damage to the lungs. In case of high frequency, your static strain is more, but your dynamic strain is very less as compared to conventional ventilation. So that's why actually high frequency we use. High frequency we call it as actually a gentler ventilation, and the chance of lung injury as well as strain to the lung will be less as compared to conventional. So either you are using for rescue ventilation or primary mode of ventilation. So I'll take you through a case. So and while discussing, actually we will discuss what we need to do and how to go about whenever you are thinking of starting high frequency. So we had a baby who is a late preterm, 2.2 kg, and with very bad lungs. So after giving surfactant also, so these were the lungs, and baby on conventional ventilation reached a higher setting, so is crossing safe limit. So this baby we have done high frequency last week. So this baby had PIP of 22, PEEP of 6, rate of 50, and mean airway pressure of 11, and FiO2 is almost 70-80%. So that means actually we have reached the almost safe limit of conventional ventilation. And yeah, as you can see the lungs here, so very bad. So if I have to set up high frequency in this baby, so what are all the things we need to do? So first thing is, in any ventilation, whether it's a CPAP or conventional ventilation or high frequency, you know your machine first. So you should know in and out of your ventilator. So either it's SLE 5000 or 6000 or VN 500. So if you try to use the same ventilator, and you also train your staff as well as residents, so the same ventilators for high frequency, so that actually the management will be easy and your staff get tuned to your ventilator. And another important thing is after knowing the ventilator and after setting up the ventilator, so patient setup, so baby setup. So what are the changes you are going to make in the baby? So one is endotracheal tube change. So sometimes actually you may need to change the endotracheal tube to a bigger size endotracheal tube, because in high frequency, as I told, you are operating at very small tidal volumes, and if there is any peritubal leak, actually there will be significant pressure drop. So as you can see in this particular graph, so on y-axis it is the pressure drop, which happens with different sizes of endotracheal tube, 3.5, 3 and 2.5. As you can see here, actually 2.5, the pressure drop is significantly more, and it occurs earlier also. So you may need to use a higher size endotracheal tube. So whenever you are starting high frequency ventilation. Second important thing is sedation and sometimes muscle relaxant. So you need to use very sparingly. So many babies actually, in the beginning we don't start sedation. So you monitor the baby, you look at the pain score as well as whether the baby is agitated, and depending on that, actually if the baby requires sedation, we start fentanyl infusion. Otherwise, usually at the beginning we don't start. So sometimes in a bigger baby, so is fighting, and if there's a lot of asynchrony, so you may need to use muscle relaxant in an occasional baby. Again, suctioning. So before connecting to high frequency, endotracheal suctioning is very important if the baby is already on conventional ventilation, because even the small amount of secretions, mucus plug, can cause problems, and actually it may dampen the high frequency ventilation. So, and you have to optimize the blood pressure. You have to optimize the blood pressure. So sometimes you need to give a bolus of 5 to 10 ml per kilo to increase the blood pressures, because once you are doing lung recruitment, which I'm going to discuss actually in next few minutes, so the baby can have actual decreased venous return and hypotension. So basically you need to give a little bit of more fluid initially, and you have to optimize the blood pressure and hemodynamic status. So fluid, calcium and inotropes may be required. And PPHN. So if a baby, so most of the babies like MAS with PPHN, so this is the commonest indication where you start high frequency. So if a baby has oxygenation index which is high, so you may need to start nitric oxide, so which we are going to listen in the next session. So basically you need to consider, whenever you want to start high frequency from conventional, you need to consider the lung disease, and you should have clear plan of ventilation strategy, and simultaneously you make a note of delta P. So what is the delta P in the conventional ventilation, and also the MAP, as I was telling in the previous example which I have given. So MAP mean airway pressure was 11, so at the time of like failure of conventional ventilation. And also keep a note of delta P, because your amplitude that you are going to set is dependent upon delta P also. So for example, if a baby is on 24/6, so your delta P is 18. So keep that in mind. And you have to perform endotracheal suction, as I discussed in the previous slide. So now, so you have set your machine, and now what are the circuit factors to be considered while using high frequency ventilation? So here, this is again another important aspect. Like whenever you are thinking of starting high frequency ventilation, you may need to change your ventilator circuit also. So these are particular properties of the ventilator circuit which you should have idea. So the ventilatory tubings which you are going to use should be very stiff. There should not be any kinks, and it should be short as well as straight as much as possible. Use heated circuit, so both inspiratory as well as expiratory if possible. Earlier actually we were getting like expiratory one which is containing water trap. Now actually the expiratory one also contains inline heating. I'll show you that one. And avoid condensation in the breathing circuit to minimize the resistance to airflow. So there should not be any condensation, because the small droplets also can hamper your high frequency. So as I was just mentioning, the type of circuit. as you can see here, the inspiratory circuit, blue one, as well as expiratory circuit, both of them actually they are having inline heating mechanism. So the earlier versions, like they don't have this kind of thing. So they used to have water trap. So earlier it used to be there both in the inspiratory as well as expiratory circuits, so which is not desirable, because so it will lead to volume loss. Also, that effective tidal volume delivery won't be good. And another important thing is, like if there is any leak while fitting this water trap, actually it will again hamper the high frequency delivery. So now, so you have done with your ventilator as well as circuit. So what are the parameters to set in the ventilator? So what are the parameters you have in high frequency? You have total 5 parameters which you need to set: map, frequency, amplitude, FiO2, and IE ratio. So it is conventionally said that actually in high frequency ventilation, the oxygenation as well as CO2 are taken care by map as well as amplitude. The oxygenation is taken care by map, and amplitude will take care of carbon dioxide removal. So this is correct, but it's not the entire truth, because actually the oxygenation as well as CO2 removal, they are dependent upon even other factors also. For example, the oxygenation is not only dependent upon the map, it also depends upon recruitment of the lung. So this is one of the very crucial factors. If you recruit the lung properly, even with lesser map, actually the oxygenation can be better. So this is another important point which you need to understand. Similarly, the CO2 removal is not only dependent upon amplitude, it also depends upon other factors like frequency, IE ratio, as well as if you have set any volume guarantee in the ventilator or not. So what are the factors that determine these 5 settings? So I'm going to discuss some of the key points. So because these are the ones actually which are going to be helpful for you at the bedside. So whenever you are setting MAP, mean airway pressure, so basically there are 3 things which you need to remember: whether it is a high volume strategy or low volume strategy, or third thing, like if you are starting for a primary mode or a rescue mode. So these are the things actually which determine the map which you need to set. So if you are using high volume strategy, the first group, so for example, severe RDS, infective pneumonitis, chemical pneumonitis fall in this category. It should be 1 to 2 centimeters above the conventional ventilator. So in the example which I have given, so the baby was already on map of 11. So here you start at 12 or 13 actually to begin with. Whereas in case of low volume strategy, if I am doing high frequency for air leak or PPHN or pulmonary hypoplasia or meconium aspiration, here it should be 1 centimeter to 2 centimeter below the map on the conventional ventilation. So if you are starting for primary mode, you can start with relatively lesser value like the 7 to 8 or even 6 also. So that is regarding map. So that is the starting setting. So how to titrate further, we are going to discuss. So now about frequency. So what about frequency? What are the factors which influence your initial setting of frequency? So one thing is size of the baby. So if you have a smaller baby, the higher the frequency. So baby, compare 1 kg baby and 2 kg baby. 1 kg baby will require higher frequency as compared to 2 kg baby. So this is because of the resonance properties of the trachea. So smaller trachea, shorter trachea will require higher frequency as compared to a longer trachea. So second important thing is lung disease. If you have a homogeneous lung disease, like the case which the baby which I have shown, so you need to keep a higher frequency as compared to inhomogeneous lung disease like a meconium aspiration. And if there is obstructive pathology, for example, bronchopulmonary dysplasia, so you need to use lesser frequency. And if you want better CO2 removal, so again you decrease the frequency. So which means that actually, like, this is in sharp contrast to your conventional ventilation. In conventional ventilation, what we think generally or what we are taught is, so if you increase the frequency, the minute ventilation will increase, so CO2 removal will be better and CO2 will drop. Whereas in high frequency, this is quite opposite. So if you reduce the frequency, there will be a longer time for the gas exchange to occur. There will be a longer time for the gas exchange. So there will be better CO2 removal. So if you want CO2 removal, you keep a lesser frequency. So once set, actually this is one of the less frequently changed parameters. So you don't titrate it too much based on the blood gases or clinical status. Once you are set, so usually you keep that frequency to next probably 12 hours or 24 hours. You don't change it too frequently. You can titrate your MAP, your FiO2 as well as amplitude based on your blood gas as well as clinical scenario. So these are some of the facts about frequency. So you have like time constant is the one which determines frequency. For example, if you have a stiffer lung, the time constant will be less, because whatever the pressure you are giving at the proximal airway, immediately it will reach the distal airways. So the time constant will be less. So you need more frequency. So stiff lung requires more frequency, and if it says again smaller lung will require more frequency as compared to a larger lung. And you can't change it too much. Actually, there are risks of going too high or too low in the RDS lung. For example, the usual operating range of frequency in case of RDS is like between 10 to 15. So you can't go beyond 15 or so. So these are some of the practical things actually. So if you have a preterm RDS, you are operating at 12 to 15 heads. If you are ventilating, if you are doing high frequency for meconium aspiration, you are operating at 7 to 9. Sometimes you may need to go as below as like as down as 6 or 5. If you have a term baby with lung disease, so usual operating range is around 9 to 12. And if you have a baby with air leak, cystic PIE is there, and baby is requiring high FiO2, CO2 retention is there. So here you need to remove the CO2. So you need to keep lesser frequency. So you may need to go down as low as even 6 or 5. So we have discussed how to set MAP and how to set frequency. Now on the bedside, so how to decide upon the amplitude. So amplitude, this is one of the very important thing in high frequency. So it is basically otherwise called as wiggling. So whatever amplitude you are setting, it will be reflected on wiggling of the baby. So it is basically marker of the tidal volume, and clinically what you need to assess how much is the wiggling. So what is desirable in case of neonates is the wiggling should be visible up to the umbilicus. So if it is almost like to the lower abdomen or thigh, so then it means actually whatever the amplitude you are giving is more, you need to come down on that. And this is one of the main determinant of the CO2 removal, as we discussed. It is generally said that actually it's like a rule of thumb. So you can set amplitude at 1.5 into delta P. For example, in the previous baby, 24/6 pressures on conventional ventilation. So your delta P is how much? 24 minus 6, so 18. So how much is the amplitude? 18 into 1.5. So it will come to 27 like that. So you can start with anywhere between 26 to 30 amplitude, and you can titrate it further. So just go through this particular video. So this baby on high frequency last week. So here, as you can appreciate, there is a wiggling of the chest as well as abdomen up to the umbilicus. Probably it is extending even below the umbilicus. So the amplitude is slightly high. So your wiggling should be up to the level of umbilicus. So now fourth one, so IE ratio. There's not much of option in IE ratio. Like usually some ventilators by default they use either 1:1 or 1:2. SLE 5000 has two options, like 1:1 and 1:2. Both the options are available. And in SLE 6000 even 1:3 is also available. But usually like 1:1 and 1:2. So these are the two ratios which we use. So if the CO2 elimination is a concern, so baby is having hypercarbia, then use 1:2. Whereas if oxygenation is the main concern, then use 1:1. So now how to recruit the lung. So now this is one of the very important aspects. Now I am going to discuss, this is one of the important part of my talk. So how to recruit the lung while starting high frequency ventilation. So I would like all of you to focus here. So this is the standard PV loop. So I think you might have seen in each and every talk of ventilation. So any ventilation talk will contain this loop, and it's a really fascinating loop. And each time when you see this particular loop, and each time actually you know one new point regarding your own lung. So what happens here? And this particular PV loop is more important in high frequency ventilation as compared to CPAP or even conventional ventilation also. And I'll tell you why. On x-axis here you have pressure, and on y-axis it is volume. And as you can see here, actually this is the inspiratory limb, and this is the expiratory limb. So initially what happens, like when you are trying to inflate, so in the initial part, so actually you need to put a lot of pressure to make minimum change in the volume. Here the compliance of the lung is less. So even with more pressure, the change in the volume is less. Once it reaches a particular point, the compliance will suddenly increase. So per unit change in the pressure, the change in the volume is also more. And once you keep on increasing the pressure, what will happen? So it will reach a phase of over distension. So at that point, even if you increase the pressure more and more, so then there won't be much change in the volume again. So it will reach a plateau. So this is, so here actually you have three phases. So this first phase, these 2 points are called upper inflection point as well as lower inflection point. So lower inflection point and upper inflection point. So basically in this phase, the compliance is less. Here the compliance is better. Again here the compliance is less. So this is what happens to the dynamic compliance. But another important point actually, which is more actually clinically relevant in case of high frequency, is the expiratory limb of the this thing PV loop. So this is called hysteresis. So if you gradually reduce the pressure in the lung, so it won't take the same path. So it won't come back like this. So it will go on to a different path. So it means that initially there will be fall in pressure, but the volume is not going to change much. And at one point again, suddenly it will drop. So it is almost comparable to balloon. So you might have seen or you have blown on your own. So initially there will be difficulty while blowing, and after a certain time actually it will be very easy, and once it reaches phase of over distension, it will be difficult, and again once it comes back, suddenly it collapses at one point. So the same thing here. So here you need to understand two important pressures. One is called critical opening pressure and other one is called critical closing pressure. So here actually if you observe this thing, actually this is called critical opening pressure. So where actually the compliance is suddenly increasing. Whereas actually if you are coming back like this, so suddenly it will collapse. So it is called critical closing pressure. So here the objective is to keep the lung in a safe window. So you need to operate in the safe window and keep the map just above the critical closing pressure. So what you do is actually you go up on the pressure. So in the ventilator, you gradually go up on the pressure. You go up and go up. Once so actual recruitment maneuver, with example I'll tell you. Again, once you come back, so you'll see sudden fall in saturation, and there that is called critical closing pressure. So the objective is you need to operate at this level. So after recruitment, after the lung is recruited, all the alveoli are recruited, if you keep the lung in the expiratory limb, so you can get better volumes at a lesser pressure. As you can see here, so here the pressure is more, but the volume is less at this particular point, critical opening pressure. But at this point, critical closing pressure, here with a lesser pressure, you are able to get more volume. So this is one of the very important aspect you need to understand while doing recruitment maneuver and while doing high frequency ventilation. So that's what we do when you start high frequency ventilation. So you recruit the lung and you bring the lung into the expiratory phase of the PV loop, and there you need to operate. So practically how to do with example, I will just tell you. So for example, so if you are doing from rescue ventilation, like if you have shifted a baby from rescue like conventional ventilation to high frequency, which you call it as rescue high frequency. So you start MAP somewhere around 10 centimeters of water and it changes the FiO2 to give a saturation of 90%. So these two changes, MAP and FiO2. And gradually, like every 5 minutes, you increase the MAP by 2 centimeters of water. So from 10 to 12, you go up 14, go up 16, like that. So at one critical point, actually the SpO2 suddenly jumps and chest wiggling increases because the compliance is increasing. So suddenly your chest wiggling also will improve, as well as the saturation also will suddenly jump to 98 or 99, like that. So this is called critical opening pressure. So which means actually you have reached this point, critical opening pressure. So here you need to be patient, like you don't make your changes too frequently, like every 1 minute don't increase by 2 and 2, like that, because here actually you are using very low tidal volume, so it will take some time for the equilibration of the pressures to occur. So whatever you are giving here, it will take some time. So just wait for 5 minutes after each change. So from 10 to 12, 5 minutes, again from 12 to 14 after 5 minutes. So once you have reached this point, now actually the lung is getting more and more recruited. So keep on increasing the MAP. So for example, here it is 14 or 16. So make it 18, 20, like that. And keep increasing the MAP. Here the saturations are already high. So now by increasing the MAP, you can come down on FiO2. So this is called recruitment. So the baby is in now this phase, second phase. So at one point again, like if you keep on increasing the MAP, so you are not able to decrease the FiO2 further. So when you reach this phase, so the saturation won't, the saturation may even drop also, because you are decreasing the FiO2. There is no change in the lung volume, but FiO2 if you are decreasing, so there can be slight drop in the saturation. So then you have reached a phase of over distension. So that means actually the recruitment has done. So now you need to again come back. So it is called like gradually you come down. For example, here you reached 26 or 24. So you come down by 2 every 3 to 5 minutes. 24 to 22, come down, come down, come down further. So until the saturation falls. So at this point, actually the saturation will suddenly starts falling. So this is called closing pressure. So a critical closing pressure, which we discussed. So now you keep the MAP just above that closing pressure. So for example, if it is 12 here, you keep it 13. So that is called the optimum MAP. So that is what the recruitment maneuver is. I hope you have understood. So I'll just tell you what we have done in our particular baby also. So in this baby, when we started for rescue high frequency, so the baby is already on 22/6 pressures. So which was corresponding to MAP of 11. So we started with the 12 and we kept increasing the MAP. So at 18, actually there is sudden change. So again, we kept increasing the MAP. So till we reached almost like 24 and we came down further. So came down further. So at again 15 actually, so the saturation suddenly dropped. So which means that actually 15 is the critical closing pressure. So you can keep 15 or 16 as your MAP, set MAP. So which means that actually you are getting more volume even at a lesser pressures. Here as you see, even at 18 pressures the volume is less. Here at 15 pressures your volume is more. So that is the biggest advantage of doing recruitment maneuver. So similarly, you can do the same thing for RDS lung if you are using for primary mode also, not the rescue high frequency. If you are using for a primary mode, if you are using a HF in a tiny baby, 25, 26 weeker with 700 gram high frequency, you do the same maneuver like, but here actually the map requirements will be much less. So usually the lung is not too bad. So if you are starting more to reduce the lung injury, then you can start with the lesser pressures, and you may be operating at like 10 to 12 pressures like this. So this is another example, like after giving surfactant, your PV loop will shift left, and your critical closing pressures also will be much lesser. So your critical closing pressures may be even 9 or 6 or like that. So now we have discussed the second important aspect of the talk. So that is lung recruitment maneuver. So now, how to do monitoring and what to do in the monitoring aspect. So frequency of your X-ray, usually like in the first 24 hours you may need to every 8 to 6 to 8 hourly, but gradually, like once the baby settles, so subsequently you need not do too frequently. And again on day 1 and day 2, babies will require ABG frequently. So if you have an option of transmittance measurement, so you have to do transmittance CO2 monitoring, but in most of the units it is not available in India. Of course, hemodynamic monitoring, your heart rate, saturation, blood pressure, urine output, all those things, perfusion parameters which you need to monitor. And once the baby is already on high frequency, so you monitor the wiggle or the amplitude that the baby is getting. So you look at the wiggle, so whether it is same or whether it is increasing or decreasing. So the wiggling changes with the compliance. So once you give surfactant to the baby, suddenly the wiggling will increase. So then you need to reduce your map as well as other parameters. So, and the second important thing is even minimal secretions or a small mucus flex also can dampen your high frequency, and actually the wiggling can reduce. And another parameter which is displayed in most of the high frequency ventilators is tidal volume. So tidal volume of high frequency. So that also you keep a constant monitoring. That should be noted in the monitoring sheet so that you know what is happening to the tidal volume in the high frequency. Usual desired tidal volume is around 2 ml per kg. So for a 1 kg baby it will be 2 kg baby it will be 4. And another thing which you can monitor on the ventilator screen is DCO2. So what is this DCO2 and how to monitor, and what is the clinical implication of this? So DCO2 is nothing but it basically tells about gas transport coefficient. So it basically tells about the CO2 diffusibility. So otherwise called CO2 diffusion coefficient. The formula for this is VT square into frequency. So VT square into frequency. So it is displayed on the ventilator. So this is a screen on SLE 6000 ventilator. So it's written as DCO2 144. So you can see the trend of DCO2, what is happening in this particular baby. So for example, you have a 1 kg baby with 2 ml per kg as the tidal volume. The baby is already on 10 hertz of frequency. So how much will be the DCO2? So it's 2 into 2 into 10. So it will be 40. So if you see the trend, like after 6 hours, what is happening to the DCO2? After 12 hours, what is happening to the DCO2? Then you will know what is happening to the baby, and you can also correlate with the PCO2. So you can monitor the trend in on the screen. And if this DCO2 decreases, PCO2 increases. So because if there is a better diffusion, the PCO like if the DCO2 is low, the PCO2 will increase, and it's vice versa. But usually there is no linear correlation. That means it's not that you can estimate the PCO2 level based on the DCO2, but it will tell, like if you your DCO2 is less, then your PCO2 will increase. So what are the complications to high frequency, and what are the things which we need to keep a watch, doctors as well as nurses? So the baby may get agitated, irritated. So baby may need sedation. So start with either fentanyl or morphine. So fentanyl dose is 1 to 2 microgram per kg per hour. And if there are like if there is inappropriate humidification, so if the humidification is not good, then actually the secretions as well as mucus plug formation can occur. And another important complication is necrotizing tracheobronchitis. So this is more specific for high frequency. It can also occur in conventional, but actually as you are using very high pressures at the proximal airway, the necrotizing tracheobronchitis is a more of a complication in case of high frequency. And hypotension, especially in the beginning, like when you are doing recruitment maneuver. So here you are increasing the MAP. So what can happen is your venous return can come down and baby can have hypotension. And there can be sudden hypocapnia. There will be a lot of CO2 fluctuations in case of high frequency, because like if the competence increases and if you don't change the amplitude, suddenly the CO2 may drop and it can lead to cerebral vasoconstriction. And intraventricular hemorrhage is a described complication, but as you can understand, so these complications will reduce with experience. So if your unit is too much into high frequency, definitely all these complications will be less. And with newer modes also, like if you use other things like volume guarantee, if you use flow sensor, volume guarantee, so all these things will reduce your complications. So these IVH and these complications are more in pre-surfactant era, as well as when there are no flow sensors, as well as volume guarantee modes. So what are the other aspects of nursing? What you need to give instruction to the nurses in case of when a baby is already on high frequency? So proper humidification is must, because actually you are using very high frequencies, almost like high flows. So the bias flow can be here almost like 15 to 20 liters per minute. So the ventilator, through that ventilator circuit, almost 15 to 20 liters per minute of flow is going on. So it will take away a lot of water with the gas flow. So the consumption of that deionized water in the humidifier chamber will be very high. So you may need to replenish it every probably 6 hours or even less than that. And avoid condensation and water droplets in the circuit, because it can again affect your delivery of high frequency. And remove the condensed water from the circuit very frequently without disconnecting. So just by allow it by drop into the just by gravity, actually it will drop into the humidifier chamber. So just allow it. And if you need to do ET section, another important aspect while doing high frequencies, so you need to do closed suction. So here actually in conventional ventilation you can do open section, but in case of high frequency, as much as possible, so use closed suction. So you need to use connectors actually for that, and some ventilator circuits they have direct option of doing closed suction. So if at all actually you need to disconnect the ventilator circuit, that recruitment maneuver, all that maneuver has to be done again, but you need not go slowly, because you already know what are the pressures, what is the critical opening as well as closing pressures in that particular baby. So you do rapidly. So this is what I was just mentioning. Inline humidification option also is there. So if you want to, for example, humidifications, just to put the water, this deionized water into the humidifier chamber, don't disconnect the humidifier chamber. So sometimes some of the nurses they do that, but you use inline humidification, so that actually when this water is getting depleted, it will get automatically filled up. And always it is desirable to have UVC as well as UAC. So this particular baby, I'm not sure whether you are able to appreciate the UAC. This baby also had umbilical arterial line as well as umbilical venous line, because your blood gas you need to do frequently, you need to monitor all these parameters. So it's highly desirable. And you tell your nurses to do clustering of the care. So don't touch the baby too frequently. So just as you tell in your developmental supportive care, so do clustering of the care, club all the activities together. So for example, doing sampling and changing the nappy and all these things to be clubbed. So sedation, I have already mentioned. So avoid paralysis as much as possible, and positioning of the baby. So any position you can keep. So supine or right and left lateral, depending on the particular clinical situation. So sometimes actually you need to do even prone ventilation also. So very difficult to ventilate lungs. if you are using, if there is significant hypoxemic respiratory failure secondary to severe lung disease, you may need to do prone ventilation. And it's easy to do prone ventilation in neonates as compared to pediatric and adult age group. The other important thing is repositioning. Usually you tell the staff to change the position of the baby every 6 hours like that. So for the routine conventional ventilation. So you should give actually baby oriented directions to the nurses. So whether that repositioning is required or not. So if at all the nurse is doing repositioning, don't disconnect the circuit and ensure the ET is secure. And again, like once the staff repositions the baby, assess for the leak around the endotracheal tube, and again check for the positioning of the lines. And some babies may require nebulization. So if there are thick secretions, insufficient secretions, they may require nebulization. So always it is advised to use ultrasonic nebulizer. So this is the one which we use, AeroNeb, in our unit. So ultrasonic nebulizer. And simultaneously, like if you are using this particular nebulizer, remove the flow sensor at the time of nebulization. So otherwise, actually, like with this flow, as well as even with the clogging of secretion, the flow sensor will get damaged. And care of flow sensor is very important, and its flow sensor is very costly also. So if you lose that flow sensor, so it's difficult to replenish. Now, if there is acute deterioration, so what to do? So this can happen. Actually, one thing is during recruitment maneuver. So especially what can happen is the blood pressures may come down. There can be hypotension and hemodynamic instability for the reasons which I discussed. So you are increasing the intrathoracic pressure. The venous return may come down. And as in conventional ventilation, of course, you have to keep in mind DOPE, your tube displacement, obstruction, pneumothorax, as well as equipment failure. So how to pick up pneumothorax? It's not so easy. Sometimes you may find asymmetric chest movement, decreased wiggle, and unilateral air entry, but these are like unreliable. So if there's sudden deterioration, you have to think of, and you have to put a cold light. So always prefer to keep the cold light by the bedside if the baby is already on high frequency. So if there is obstruction, so usually even for minor obstructions like mucus plug as well as secretions also, it can hamper the high frequency, and the displacement is one more thing. So, and usually, as you know, babies, they don't follow the rules. So you have to individualize your ventilation. So each baby is different, and each baby airway as well as lung pathology is different. So you need to individualize, and you need to see what are the settings which suits the baby best. So during procedures, what to do? So many times actually we order for echo. So a baby is requiring surgery. So these are the different situations, isn't it? For example, if the pediatric cardiologist comes, or you are doing functional echo, so in your unit, so there is an option of oscillatory pause. So in some of the ventilators, so SLE 6000, it has got this oscillatory pause. So if you press that button, what happens is it will pause the oscillations, but it will maintain the mean distension pressure or mean airway pressure. So for almost like 60 seconds. So you can again restart and the high frequency. So during echo, like because if there is too much of oscillation, sometimes it is very difficult to pick up the findings. And second thing is during surgeries, like for example, baby is a case of CDH, already on high frequency and INO. So how to shift the baby? You can always, rather than converting into conventional ventilation, you can shift the baby to the operation theater on high frequency itself. And during suturing also, like in operation theater, actually if the surgeon wants to take a suture, for example, if it's a TEF surgery or CDH surgery, again you can also use oscillatory pause in these situations. So here actually the mean airway pressure is maintained, the lung is recruited, and there won't be oscillation at the time of taking that bite suture. And for example, like the surfactant. So baby, you have started already on high frequency and baby requires surfactant. Many times actually we are disconnecting and using because we are not getting these double human endotracheal tubes. Earlier actually we were getting And these days, after this GST, actually the vegan people, they are not able to import this. So earlier, vegan used to have this double lumen endotracheal tube. So volume guarantee, we had a full lecture on volume guarantee, so I'm not going into the details. But if you use volume guarantee, the chance of complications as well as air leaks, barotrauma, so they will reduce. So what are the variations in practice in high frequency? So across the country, actually some people, most of the people use as a rescue mode, but still some people like, especially if the baby is a very tiny baby, 700, 600 grams baby with very stiff lungs. So you can also use as a primary mode, as a gentler form of ventilation. And another variation is actually extubation. So during weaning, so some people before extubation they shift to conventional ventilation CMV, and after that they extubate. Some people directly extubate from high frequency, and to my mind, actually you can directly extubate from high frequency ventilation. So how to wean, the last part of my talk in next couple, I'll finish in next couple of minutes. So basically here you have done, you have initiated, you have monitored, and you have titrated your settings and how to wean. So you should always know how to come out once you start your high frequency. So some of the important principles while weaning high frequency are, you have to wean the oxygen first and map subsequently, and keep the frequency same, don't change frequency too much as I told you earlier. And you switching to conventional ventilation as I was just telling, it's an individual choice. So extubation to non-invasive ventilation. So whenever you are extubating, you are always extubating to non-invasive ventilation. So in less than 1 kg babies, you come down on MAP to 8 and FA out of 25%. And in more than 1 kg babies, MAP of 9 and FA out of 30%. So thank you very much for your kind attention, and I'm happy to take any queries at the end of the session. Thank you. Thank you.
Yeah, thank you very much, sir. So, Dr. Abhishek. Yeah.
Yeah, thank you, Dr. Sai Sunil. It was a very practical and clear presentation. So now we will move on to the next presentation by Dr. Leslie sir on inhaled nitric oxide. Over to you, sir. Leslie sir.
Prashanta.
Yes, sir. Yes, sir.
If there is any questions till Leslie comes, please tell Padke to ask.
Yeah, there are couple of questions to Dr. Sai Kishore. What should we do if we do not have a closed section catheter on HFOV? How do you recruit the lung later? This question is by Dr. Raj from Singapore.
Yeah, this is a very practical question. Actually, for doing closed suction, you sometimes you need to use the connectors. So some of the ventilator circuits, they have that option of closed suction. But if you don't have that closed suction, or if you are not able to do, then as I was mentioning in my talk also, you have to do that recruitment maneuver. But here you need not be too slow. Like you need not hike up your settings every 5 minutes like that, because you know your critical opening pressures and you know your critical closing pressures of the lung. So you go up and rapidly again come down, so that you keep just above your critical closing pressure.
Correct. Yeah. And also the closed section equipment is also quite expensive. I mean, many units might not be able to afford it.
Yeah.
Yeah. And another question is, why do we use stiff tubings in HFOV circuits?
Yeah, it is quite understandable, because in conventional ventilation you are using very higher tidal volumes, so like 6 to 9 ml per kg. For example, you have a 3 kg baby, so there actually the tidal volume is like 24, 25 ml. Whereas in case of high frequency ventilation, you are talking of almost 1.5, 2 ml per kg. So for a same baby, it will be like 6 ml. So if the tubings are too compliant, that means if they are not stiff, so whatever the volumes that are being delivered, so there is a chance that actually it will be lost in the circuit itself. So if it is stiffer, the stiffer tube will allow the better pressure delivery as well as better amplitude delivery to the baby as compared to this thing, softer or compliant tubing.
Thank you, Dr. Sunil. I think Leslie sir is online. We will move on to the presentation and remaining questions we'll take up at the end of the session. Over to you, sir.
Yeah, thank you, Abhishek. And at the outset, I thank NNF Karnataka, Dr. Kishore, Dr. Kotresh, sir, Dr. Prashant, Dr. Dinakara, for giving me this opportunity. I'll also thank my team, which is working with me day and night, our postgraduates, nursing staff, respiratory therapy, interns, postgraduates, and without forgetting our biomedical engineer. So I'm going to talk on the use of inhaled nitric oxide in neonates. So I will be covering up on this aspect, indication to use inhaled nitric oxide in neonates. What is the evidence? How safe this drug is? How to set up a inhaled nitric oxide? How to calibrate the gas? What are the adverse events and monitoring of inhaled nitric oxide? And how to wean the inhaled nitric oxide. Nitric oxide is one of the potent pulmonary vasodilator. It is produced from endothelial derived relaxing factor, or we call it as EDRF. It's a therapeutic vasodilator to the target organ. And the beauty of this inhaled vasodilator has no systemic hypertension. Whereas the other drugs which we use for a treatment of PPHN has always associated with systemic hypertension. Only one of the side effects is this drug has got a high affinity for heme proteins. So I'm saying as a drug because even though it is an inhaled gas, we have to treat like this, use as the specific dosage, everything like a drug only this is. Newborn baby has got a good amount of a nitric oxide at birth. And nitric oxide has got a good effect, especially if you look into the lung parenchyma, a bronchi, and the vasculature. Even in the brain, there's a good amount of nitric oxide being produced. In the lung parenchyma, the nitric oxide helps in the growth, helps in the production of the surfactant, reduces the elastin production, and reduces the inflammation. When it comes to the bronchi, it helps in the bronchodilation, reduces the airway smooth muscle proliferation, and that is the reason it used as a vasodilator. And at the vasculature level, has got a increased effect on the vasorelaxation as well as the angiogenesis. This is a beautiful slide from Dr. Satyan Narasimha and his group. And I think all of you know that the two most popular Indians working in USA has worked in PPHN for the last decades. And a lot of the leading articles in good journals is coming from Dr. Satyan Lakshmi Narasimha and Dr. Ganesh Konduri. I think these are the two people has extensively worked on pulmonary hypertension in neonates, nitric oxide, and use of other drugs. Now, if you look into the lungs, as I mentioned, nitric oxide is endogenously produced. And the enzyme which is present called as nitric oxide synthase, which convert the L-arginine to nitric oxide and citrulline. And this nitric oxide is a lipophilic substance which diffuses directly into the vascular endothelium. And the beauty of this drug is the half-life is only 3 to 6 seconds, a very labile. A few seconds only it acts. And within that period, this nitric oxide diffuses into the vascular endothelium, and there it's usually converts into a hemoglobin to a methemoglobin. So presence of a methemoglobin is one of the toxic metabolites which presents while using a inhaled nitric oxide. So we need to monitor the presence of the methemoglobin levels. The another side effects which presents is because this nitric oxide is a free radical. It has got an affinity to combine with oxygen, and when combines with oxygen, it becomes the nitrogen dioxide. Again, the nitrogen dioxide is also a toxic to the pulmonary system. So these are the two side effects what we get when we give a oxygen mixed with the nitric oxide in the alveoli. That is the production of a methemoglobin and nitrogen dioxide. So we will look into that, how much methemoglobin we can maintain, how much nitrogen dioxide is maintained, and how safe these are two side products of a nitric oxide. As I mentioned, the first important thing, this endogenous nitric oxide which is present to act, as well as the exogenous nitric oxide to act, is we should have a healthy alveolus. To have a healthy alveolus, we need to have these alveoli to be recruited. Only once these alveoli are recruited, or disease alveoli recruited, then only the nitric oxide is going to act. Otherwise, in a disease alveoli collapsed, the pulmonary vasculature is constricted, and the use of a nitric oxide mixing with the oxygen is not going to benefit at all. So the first message I want to convey all of you is, remember, when we use a nitric oxide, the lung has to be recruited well. And I think last 1 week, including Dr. Sai Kishore, has explained very well the maneuver of a lung recruitment. And only once the lung recruitment comes, and then still we are not able to maintain whatever the required oxygenation in that particular baby, and that is the point where we're going to use a inhaled nitric oxide. If you look into the chemistry of this drug, it is a colorless, is an odorless gas which is soluble in water. We have a good amount of environmental nitric oxide, which comes from the combustion process and lighting. And the nitric oxide which presents in the environment, it ranges from 10 to 500 parts per billion. Now, how does this commercially, the nitric oxide is available? If you see in the metropolitan cities, especially Delhi, and in the month of September, October, we can see the smog. The smog is nothing but, it is the nitric oxide which is the produced from the reaction of this the automobile waste. Similarly, in the industry, commercial industry, nitric oxide can be produced from sulfur dioxide mixed with the nitric acid, or when ammonia and platinum catalyst work at a high temperature of more than 500 degrees centigrade, it also produces the nitric oxide. And in an anaerobic environment, that is, it is a highly purified nitrogen. A nitric oxide can be stored in the cylinders for several years. If you look into the chemical properties of this nitric oxide, as I mentioned earlier, nitric oxide is a free radical, which is endogenously present and present in many cells. This nitric oxide, when combines with the oxygen, it forms nitrogen dioxide. When we use higher amount of oxygen with a ventilation, let's say about 60% or more than 60%, 70%, 80% or 90%, there is another free radical is present, superoxide. When nitric oxide combines with the superoxide, it forms what is called as peroxynitrate. So nitrogen dioxide as well as the peroxynitrate, these are the two potential vasoconstrictors which forms following the inhalation of the gas with the oxygen. So any levels of inhaled nitrogen dioxide, that is more than 10 parts per million, induces pulmonary edema, alveolar hemorrhage, and changes in the surface tension activities, reduces the surfactant production, and also leads to intrapulmonary accumulation of fibrin, neutrophil, macrophages, and leads to a cell death. So what is the recommended level of nitrogen dioxide? As I mentioned, this is a byproduct which present while we use this drug during the treatment is maximum maybe 3 parts per million, but we set up in our nitric oxide the delivering system as the monitoring system, the maximum limit as about 3 parts per million. Anything more than 3 parts per million, we should not use it. As I mentioned, the safest level could be about 1 parts per million. The lower concentration of nitric oxide, if we use this low, it also can alter the surfactant production and leads to alveolar cell hyperplasia. That is the reason when we use a nitric oxide, we use somewhere around 20 parts per million, and then we escalate quickly. And if there is no response, and then we de-escalate and we come down. So a lower level of the nitric oxide starting and then escalating is not recommended. It is recommended to use around 20. That is the standard dose. Why 20? I'm going to discuss in subsequent my slides. So when to use nitric oxide? Classically, it is the hypoxic respiratory failure, and any neonates more than 34 weeks of gestation, and the oxygen index, which is more than 25, and we are already on a conventional ventilation, or we are switched to a high frequency ventilation, and still we are not oxygenating, or our oxygen index keeps going up, but there is no good post-ductal saturation around 95 is reaching, and that is indication where if you have a facility, use the nitric oxide. The more commoner situation, I would say, any neonate, especially term baby with pulmonary arterial hypertension, is considered as a best candidate to use a nitric oxide. And we know where the PPHN can be present in the meconium aspiration syndrome, pneumonia, respiratory distress syndrome, lung, and the various lung pathology. All this leads to a pulmonary arterial hypertension. But remember, the best pulmonary vasodilator is always the oxygen. And we have been discussing in the last 1 week, non-invasive ventilation, invasive ventilation, high frequency ventilation, and still we reached the high frequency ventilation. We have recruited the lung, still hypoxic, yes, and that is an area where we are going to use the nitric oxide. A word about the oxygen index. Oxygen index is calculated by a fraction of inspired oxygen multiplied by mean airway pressure into 100 divided by post-ductal arterial oxygenation. And if you see, is a good practice if any baby on ventilator, and when you do a blood gas, always try to correlate what is the oxygen index. I think on rounds, most of our postgraduate always tell what is the pH, PCO2, PO2, as well as the saturation. But remember here, if you add one more point, what is the oxygen index in addition to FiO2 and the ventilator parameter, it always gives a precise the parameters what we are using in that ventilator. So anything between 15 to 25 where oxygen index is there and still we are not getting a post-ductal oxygenation PO2 which is more than 60 or saturation more than 95, remember that we are into our problems, and there we can switch or we can add to the inhaled nitric oxide. These are the extremes: severe oxygen index where 25 to 40 and more than 40 is what is called as very severe hypoxia. And remember that if we use a nitric oxide with a conventional or high frequency ventilation, we likely to fail at this stage. So if we are using nitric oxide with a conventional or high frequency ventilation, consider to use at moderate hypoxic respiratory failure, that is around 15 to 25 of oxygen index. Again, this is a good work by Dr. Satyan and his team. And here I want you to concentrate only on three aspects. So what are the pulmonary vasoconstrictor here? What are the pulmonary vasodilators? And what are the enzymes which is responsible for pulmonary vasodilatation? If you see here, the endothelin, which is produced by endothelial cells, is a pulmonary vasoconstrictor. The second pulmonary vasoconstrictor here is what is called as the peroxynitrate. Peroxynitrate is the side product of a nitric oxide. Okay, leave about the vasoconstrictor. Now let it go into a vasodilator. The three major vasodilators here are a prostacyclin, cyclic AMP, and cyclic GMP. Now this is a prostacyclin. Through a prostacyclin synthase from cyclooxygenase, prostacyclin is produced. And prostacyclin is converted to a cyclic AMP, and then through a enzyme phosphodiesterase 3, cyclic AMP converts into a AMP. So there are few drugs which we use to produce increased levels of a cyclic AMP, and that is the milrinone here, which acts on the phosphodiesterase 3 inhibitor, which is a phosphodiesterase 3, and which leads to increased levels of a cyclic AMP. If you look here, the endothelial nitric oxide synthase, which is responsible for production of nitric oxide inside the cell and which converts the soluble guanyl cyclase to a cyclic GMP. The cyclic GMP is another potent vasodilator, and cyclic GMP is converted into a GMP by the enzyme called as phosphodiesterase 5. And here the sildenafil acts on phosphodiesterase 5 to increase the level of cyclic GMP. When there is increased level of cyclic GMP and cyclic AMP is there, the calcium, the cytosol calcium comes down, and which is responsible for vasodilatation. So please remember, it is cyclic AMP and cyclic GMP, which is a potential vasodilator which present inside the smooth muscle cell, and they act when the calcium level comes down. And the two enzymes, the phosphodiesterase 5 as well as the phosphodiesterase 3, which is inhibited by sildenafil, and milrinone. So milrinone for phosphodiesterase 3 and nitric oxide, remember it acts here increasing the production of the soluble guanyl cyclase. So definitely it acts through a phosphodiesterase. It helps in the cyclic GMP production. So these are the three important vasodilators which we know which we can use in our day-to-day clinical practice. If we have a facility, it is an inhaled nitric oxide. And if we have a facility, a sildenafil, sildenafil now available, IV preparation as well as oral preparations. But most potent is the IV preparation. And the last few years, most of us are using milrinone. If we use nitric oxide, combination with the milrinone is always a good combination, because nitric oxide acts through a cyclic GMP, whereas milrinone acts through a cyclic AMP. So with this background, let us look into the risk factors, or which the situation where we need to, where we require to use a nitric oxide. First is called as intravascular obstruction. This is classically seen in small for gestational babies, IUGR babies, hyperviscosity, but it is not a great problem. We don't see much of these babies, and most of the babies respond well to oxygen or non-invasive ventilation or conventional ventilation. The remodel vasculature, or the right side of the left lung, where we have the remodeled vasculature, could be a diaphragmatic hernia, could be a chronic intrauterine hypoxia, or the antenatal ductal closure, or pulmonary hypoplasia. These are the group where this pulmonary arterial hypertension will be there. And these are the groups where conventional ventilation might fail, and we might have to go for a high frequency ventilation. Again, high frequency ventilation may not do a justice there. And if you have a facility, we can consider here the inhaled nitric oxide. But this is the area where the maximum benefit of inhaled nitric oxide has been demonstrated. That is the acute vasoconstriction following asphyxia, pneumonia, and classically meconium aspiration. It could be a hyaline membrane disease, or could be any parenchymal lung damage. And these are the acute conditions. And here there is a alveolar damage will be there. In addition to that, pulmonary vasoconstriction is there. And this group, in addition to a ventilation and nitric oxide, is respond well to a therapy. Please remember that this is the group, whereas the group which is present on the left side of the picture is unlikely respond to a inhaled nitric oxide. So what is the requirement for a PPHN? Is echocardiographically confirmed normal heart, a demonstration of a severe hypoxemia, could be pH 7.25 and less, PCO2 accumulation, or PO2 is less than 60 on at least 60% oxygenation, and echo confirmation of a right to left shunt across the ductus or foramen or veil. And this must be the requirement. Remember, sometimes we might be having a baby which is coming into a unit which is hypoxic respiratory failure. We start with a ventilation, do not respond, and we might switch over to a high frequency ventilation, again may not respond. But before we switch over to a nitric oxide, it is required to rule out a cyanotic congenital heart disease before we consider PPHN. So before we consider nitric oxide in these babies. So when not to consider nitric oxide, maybe a selected cases where congenital diaphragmatic hernia with the pulmonary hypoplasia, and majority of the times we might fail in the situation where there is pulmonary hypoplasia, or diffuse pulmonary hypoplasia, maybe a segmental hypoplasia, babies might respond. Cyanosis secondary to congenital heart disease, especially critical congenital heart disease, they do not respond to a nitric oxide, but nitric oxide will be used post-operative phase in these babies, and babies are less than 34 weeks of gestation with hypoxic respiratory failure. Contraindications: do not use this drug in a lethal congenital chromosomal anomalies, or the baby has got a bleeding diathesis, prolonged bleeding time, or the clotting time is there, and the platelet count is less than 20,000, be careful before we use nitric oxide. The one word about the environmental safety, there may be an accidental leakage of this concentrated gas from the delivery system or cylinder, and we need to do a scavenging of that and to prevent accidental exposure to the environment, and there the environmental level, we should keep the nitrogen dioxide below 1.5 parts million. Otherwise, if there's accidental exposure is there, and if this level goes beyond 1.5, it could be a little discomfort for the people working in the intensive care unit. They have a mild headache, tachycardia, all the symptoms will be there. And this is the scavenger system which we use for nitric oxide delivery. And this is the SLE 5000 ventilator. And this is connected at the back end of the ventilator. And similarly, all other ventilator has got the scavenging system. The port will be there to connect the scavenging system. And this is to exactly a similar system which is present in the operation theater, where the anesthetists use the anesthetic gases for the for the scavenger. So again, which patient to consider for a nitric oxide? If there is documented hypoxic respiratory failure, if a neonate is more than 34 weeks of gestation, and preferably less than 14 days old, oxygen index, as I mentioned, is around 25 or more than 25. And if you have a preductal and postductal saturation gradient, which is more than 10, suggestive of a PPHN, and the echocardiography has shown a PPHN and ruled out critical congenital heart disease, where we can use the nitric oxide in this circumstance. What is the dosage? As I mentioned, preferably we have to use 20 parts per million, and then wait for 1 to 2 hours. And when we use this drug through our inhalation, wait for at least minimum period of 1 to 2 hours. And anything which increase PO2 more than 20 or postductal, or saturation more than 10 postductal, is always indicate positive response. And that tells us that we need to continue with the nitric oxide. Suppose if we are done the blood gas or following the introduction of the nitric oxide, and which shows no improvement at all, indicates that we need to reconsider continuation of the nitric oxide. Or if we are not able to do blood gases very frequently, we can concentrate more on the postductal saturation. And the postductal saturation after starting nitric oxide has gone up more than 10 from previous, is where we consider that is a positive response. One more thing is, when we know about the oxygen index, ABG is required. And one oxygen index is not sufficient. Remember that at least we need to have 2 oxygen index parameters at a gap of at least 30 to 60 minutes to say that the oxygen index has gone up, or it is somewhere around 25. And there we need to consider for the nitric oxide. So more than 20 parts per million is not associated with greater benefit and may be associated with adverse effects. I have put here inhaler and nitric oxide if the baby is on already recruited lung, either conventional ventilation or high frequency ventilation, and started nitric oxide at 20 parts per million, and there is no response, we can escalate. I'll talk to that later. Escalate to about 40 parts per million. Maximum allowed to go up to 80 parts per million. But in clinical practice, we go up to 20, 30, and maybe 40 for a period of 30 minutes. And then if there is no response, we come back on the nitric oxide to 20 and then wean down if there is no response, and then we stop it. So the message I want to convey here, if we are not got adequate response within period of 2 to 4 hours, tells us that possibly that particular baby with hypoxic respiratory failure is not going to respond to a nitric oxide. Adverse effects: increased methemoglobin, which is, as I mentioned, our target should keep a less than 3%. The increased amount of a nitrogen dioxide, which is a toxic byproduct, and the goal is to maintain below 1 parts per million. The nitric oxide is a potent inhibitor of a platelet aggregation. As a result, when we monitor the platelet every day, if the platelet is about 1.5 lakhs, we have seen the platelet is dropping down significantly without evidence of infection, and there may be a chances of increased bleeding time also. And when we bring down the nitric oxide little rapidly, there may be a pulmonary hypertension, or if we use oxygen, which is somewhere around 95 to 100%, as I mentioned earlier, there is a release of there is a presence of superoxide which combines with the nitric oxide to form peroxynitrate. And peroxynitrate, in addition to endothelin, is a vasoconstrictor and leads to pulmonary hypertension. A brief about the nitric oxide evidence. This is a NINO study which is done in neonates beyond 34 weeks of gestation with a hypoxic respiratory failure, and they have shown the requirement of the ECMO or the death by using nitric oxide has significantly reduced to a 30% compared to a placebo, and they use the neonates near term to a term, approximately this is 235. The another study which is useful, and the continuation of this study is the NINO study for a congenital diaphragmatic hernia, where they used 53 neonates, and 76% of these neonates pulmonary hypertension was confirmed by echocardiography. And here, if you see, the oxygen index was very high, around mid-40, and they showed there no difference in the primary outcome between the INO and the control group. The mortality was high despite use of a nitric oxide. Only thing what they have showed, the neonate who are used nitric oxide, they have got initial stabilization, and consideration for a surgical intervention was better with use of a nitric oxide. The another study called as Clinical Inhaled Nitric Oxide Research Group Investigator, or SINGRI trial, which is a double-blind, randomized, placebo-controlled, multi-center trial of 186 term and near-term neonates with pulmonary hypertension and hypoxic respiratory failure. Here, they used nitric oxide 20 parts per million and weaned to 5 parts per million. And the primary objective of the study was to determine whether nitric oxide reduced the need for ECMO. The message conveyed by both NINOS and SINGRI trial is that any baby more than 34 weeks of gestation with hypoxic respiratory failure with good alveolar recruitment, if you use a nitric oxide, the chances of death comes down to a 39% to 38% compared to a 55% to 64%, which is too high. Another trial, which is called as INNOVO trial, which is less than 34 weeks of gestation and less than 28 weeks of gestation. 1 odd preterm babies, severe hypoxic respiratory failure, randomized to receive or not to receive INO, and the primary outcome was death or severe disability at 1 year of a corrected age, and they showed there's no difference between INO and control group. The same another trial conducted in a preterm neonates, where they used the nitric oxide between 7 to 21 days of age to show whether the nitric oxide benefit for a chronic lung disease, and they showed that there is some benefit of a nitric oxide when we use in a preterm babies between 7 to 21 days of age. But remember that using nitric oxide for this age group at 7 to 21 days is too expensive, and I think it is not possible in most of our center, and there is no long-term benefits. The Schreiber study, which is in a preterm, less than 34 weeks of gestation, less than 2 kilo, again showed a reduction in the BPD about 49% compared to a control of a 64%. But here, this study again showed us there is a significant reduction in intracranial hemorrhage, periventricular leukomalacia in an inhaled nitric oxide. And there are studies which are showed neurodevelopmental outcome up to 1 year of age. And most of the studies have showed that good neurodevelopmental outcome at 1 year of age. So the Cochrane has concluded preterm neonates below 34 weeks of gestation, there is not much benefit using nitric oxide in a hypoxic respiratory failure. However, there may be some benefit if we use to prevent the bronchopulmonary dysplasia. However, requires more studies. But near term or term infants, the inhaled nitric oxide used at parts of 20 parts per million term or near term neonates with hypoxic respiratory failure usually responded well, and only the circumstance with the diaphragmatic hernia, there's limited evidence or limited information or limited outcome, whereas hypoxic with the term and near term infants, the nitric oxide has done good response. This is the oxygen index versus the incidence of death. I won't say ECMO because most of us has got, in Karnataka only 4 centers or 5 centers has got ECMO. And if you see the oxygen index, the lesser the oxygen index, a chances of death is less. The message conveyed, if we use early, chances of death is less, outcome is better. And now I go to the how to deliver the inhaled nitric oxide. This is the standard equipment which is there. I think most of the nursing, the intensive care unit, some of the intensive care unit in India where uses the nitric oxide. This is called as SLA ionosis. This is the INOmax, and most of the studies, the trials, they have used the INOmax. And here, if you see the display board which shows oxygen, nitrogen dioxide, and nitric oxide. And recently, the last year, the CIGISOL has brought, this is called as SOL group, has brought GiaNOx, and this is was their display in the last Neo Gurukul workshop. Dr. Dinakar's team has brought this equipment, and I feel this is a very beautiful equipment. Reason is it shows how much nitric oxide gas is available, and how long this gas can continue. And the other machine which is available, and some of the units are used, the nursing units are using this, they take Omeda, and that is called as Innovent. So I'll just show you how to, this is called as show how to connect the nitric oxide and how does it act next few minutes. This is the nitric oxide cylinder. I will give a more explanation of that. And this is called as a nitric oxide regulator. Please remember the cost of this cylinder is about 10 to 15,000, and the cost of refilling of this gas is again 10 to 15,000 per cylinder. And from Manipal, we usually send to Bangalore metropolitan cities to refill this gas. Presently, this company called as Chemix Gases, which does the refilling and sends us to back. And this is the regulator system is there. This is where we connect the nitric oxide to our SLA 5000, 6000 or 3000 units or any conventional ventilation. It has to be connected. This is called as the nitric oxide delivery kit. And this is cost about 6,000, which is a disposable circuit. This is a disposable circuit and which is connected to the nitric oxide monitoring system. And this has to be connected immediately after the humidification chamber. And this is where the proximal limb of the proximal, or where the delivery of the oxygen to the baby, the inspiratory limb where we connect it, the nitric oxide delivery. And then this circuit is, this circuit is about 1 feet long, and immediately the other distal end, this gas, what is produced here, is monitored through this monitoring system. So it has to be connected a proximal inspiratory limb after the humidification chamber, and this should be a the monitoring system. Some places people are using what is called as low cost, the INO delivery system, where they do not have a monitoring system, because monitoring system should be available. Otherwise, people are using this delivery of this gas through the nitric oxide cylinder, which I showed, or I'm going to show further, and through the oxygen delivery, and they calculate how much parts per million is delivered through this proximal limb. But I would suggest don't use this, because we do not, we don't have a system to monitor for such delivery of the nitric oxide. This is where immediately the red, the indicator says that this is where nitric oxide is delivered immediately after the humidification chamber. And this is the green part where it is just connected to the proximal part of the inspiratory limb. And this is the gas. And once we fill this gas, the maximum capacity of this gas is about 950 to 1000 parts per million, or the smaller cylinder, the capacity is about 900 to 950 parts per million. This is the regulator. As I mentioned, this regulator is also expensive. This is cost about 1 lakh rupees, but is one-time investment. And here there are two dial systems are there. The first dial system called as the oxygen, the cylinder pressure, nitric oxide cylinder pressure, and this should be 200 psi. And the second is of the nitric oxide delivery output, and this should be at least minimum of 1 bar. So this should be working, and when you connect it, you should know that both are need to see before we connect to the nitric oxide. Here, the nitric oxide, where before we connect, sometimes need to calibrate the gas. And generally it is done by the service engineer or the biomedical engineer. This is called a sensor, which is present inside the nitric oxide. And if you can see here, this is called as nitric oxide sensor, and this is nitrogen dioxide sensor. And based on the sensor, this display nitric oxide, what is delivered to the baby in the system. And the cost of both this, each sensor costs about 40,000 rupees, and this has to be replaced every year. So the maintenance cost of this equipment comes a little expensive compared to the other maintenance system, and this has to be calibrated regularly. I'm going to tell you how to calibrate this gas. This is calibrating gases. These are the smaller canister, which is about 1.6 liter, and this is the first one on the left hand side for a nitric oxide to calibrate. Before that, first is connect the nitric oxide. Do not connect it. Connect this. There is a vent is there in the back side where we connect the oxygen or the air at 1 liter per minute. And once we zero it, then we connect this this nitric oxide, the canister first, and then it is calibrated up to 25 parts per million, which takes about almost 15 to 20 minutes. And once it is done, then we use another second canister to calibrate, that is the nitrogen dioxide, up to the maximum 5 parts per million. And this calibration has to be done every 28 days throughout the year. And this is usually done by our service biomedical engineer. That's the reason it's very important when we buy this equipment, what is the maintenance cost is required, and the backup with the biomedical engineer is available. Otherwise, most of this unit could be useless when we buy it and we are not going to use it or regularly service this nitric oxide system. And here, if you can see, once it's calibrated, nitric oxide shows that calibrated to 25 parts per million, and this is ready to use. And here in this delivery system also, there is a two systems are there where delivery systems are there, 0 to 100 ml and 0 to 500 ml. And based on the 0 to 500 ml per minute and 0 to 500 ml per minute, where we can calculate approximately how much nitric oxide delivered also, but which we need not to do because it is automatically calibrated and displayed in this monitor. How to wean? Once we start nitric oxide at 20 parts per million, wait for at least, I mentioned here 15 to 30 minutes, but wait for half an hour to 1 hour, or do a blood gas, or do a postductal saturation. If the postductal saturation is improving, a postductal PO2 is more than 20, which means that nitric oxide is working, and you wait for sometimes. A weaning is very critical because we do not wean nitric oxide immediately. We start at 20 parts per million, and there, if it is not shown improvement with 2 blood gases or postductal saturation showing improvement, which means that the nitric oxide is not showing improvement. So we can escalate to 40 parts per million to a maximum 80, but not beyond that, and come down quickly. But there also, it's not shown to 40 parts per million. We would say don't use nitric oxide. Come down the nitric oxide gradually, maybe within the next 2 hours, and stop the nitric oxide. Once the nitric oxide is started, a baby started improving, wait on the conventional or high frequency ventilation. We would say at least 12 to 24 hours before we starting weaning the nitric oxide. And we usually, our unit follow weaning down the nitric oxide. Either we bring down the oxygen to 60%, or we switch from the high frequency to a conventional ventilation. Bringing down from 20 to 10 parts per million, you can do it over 4 to 6 hours. And then 10 to 5 parts per million, you can do it over again 4 to 6 hours. But bringing down from 5 parts per million till 1 parts per million, you have to be very careful at this stage, and you have to gradually wean down. So generally, once we use a nitric oxide, shown a positive response, the total duration we use about 3 to 5 days. So and once once we wean down to us about 1 parts per million, then we can bring down our FiO2 less than 60%, and whichever the way you can go. So the message here, when shown improvement, wait for 12 to 24 hours and then bring down faster after you bring down the FiO2 or change to a conventional ventilation. But once you reach 5 parts per million, wean down slowly. Monitoring, good perfusion is required. Keep mean blood pressure more than 45. Postductal saturation should be more than 95. And good adequate gases. We do not want alkalosis. We don't want carbon dioxide washout. And we don't want hyperoxia. Remember, hyperoxia can lead to, again, rebound pulmonary hypertension. Hyperoxia or carbon dioxide retention also can lead to rebound pulmonary hypertension. Clustering of care is very important. Good hydration and good sedation, but avoid muscle relaxation. The monitoring is what we do is, after starting nitric oxide, after 12 hours to 24 hours, we have to do a methemoglobin levels, and the biochemistry lab analyze and give the methemoglobin level should be less than 2.5, or we have sometimes the Massimo set technology where we have a specific pulse, the cables, pulse oximeter cable, which is for methemoglobin is available, and which gives us continuous display of methemoglobin. And nitrogen dioxide, as I mentioned, should be less than 1 parts per million, and platelet counts to be safer, more than 50,000. Discontinuation, as I mentioned, weaned down to less than 1 parts per million, you can discontinue, and FiO2 less than 60%, and hemodynamically stable baby, where we can consider to switch to a conventional or 60% or switching down or bringing down further. And it is always the good practice to change from high frequency to a conventional ventilation. This is our data for the last 2 years. This is up to September 2019. We have, this is nitric oxide. We have used meconium aspiration with the pulmonary hypertension, 28 babies, and 20 babies survived. We lost 8 babies. Congenital heart disease, we have started cardiac surgery in our unit last 24 months, and we have crossed more than 125 surgical interventions in the last 2 years. They are critical congenital heart disease, but here we used a post-operative phase of 4 babies where who required nitric oxide has improved and 2 babies has succumbed. Congenital heart, diaphragmatic hernia with pulmonary hypoplasia, we have used 4 babies. This is before surgery and before stabilization, and 2 babies survived and 2 babies we lost. But we had a bad experience with the respiratory distress syndrome with the pulmonary arterial hypertension. Possibly they were preterm, maybe we used very late, and we lost 3 babies in that category. So when nitric oxide fail, if there is no alveolar recruitment, if there is remodeled pulmonary arteries are there, if there is enzyme abnormalities are there, or there's increased formation of reactive oxygen species, left ventricular failure, or if there is high concentration of pulmonary vasoconstrictor like a peroxynitrate or endothelin are there, or rare abnormalities like a alveolar dysplasia or surfactant protein B deficiency, where this is not going to benefit at all. Summary: use of inhaled nitric oxide should be done only after alveolar recruitment in hypoxic respiratory failure, and if facilities are available, use at early stage of hypoxic respiratory failure where oxygen index is less than 25. Titrate the dose at the earliest with clinical improvement and correlate with the blood gas values, and avoid escalating the dose about 20 parts per million. And thank you very much.
Thank you, sir. So we're going to start the discussion. Dr. Abhishek, over to you. It's a wonderful session, sir. Great feedback are coming already. Yeah, over to you, Dr. Abhishek.
Yeah, thank you, sir. It was a very, very nice presentation. You have simplified this very difficult topic with a lot of practical tips. And to all the audience, I want to say, sir is one of the authorities in the usage of nitric oxide, and he has vast amount of experience in KMC Manipal. I think it's more than 10 years now, sir, in nitric oxide in KMC Manipal.
We are using almost more than a decade.
Yes.
And right now we have a second unit also in the unit presently.
Okay, wonderful, sir. There are a lot of questions that have come up, and I think we'll start with the question session. The first question, it's on HFOV. How much chest should wiggle? What nurse should know, and what is the importance of wiggling? If it decreases or increases, what should we instruct the nurse? This question is to Dr. Sunil. Dr. Sunil, you are not audible. Yeah.
Am I audible, sir?
Yeah. Now I can hear you. Yeah. Go ahead, please.
See, regarding wiggling, actually, this is only at the beginning, like once you want to start. So you will start with wiggling. Actually, the optimal wiggling should be in neonates. Generally, it is considered to be up to the umbilicus. In pediatric age group, up to lower abdomen, and the adults, actually, if they are in high frequency, up to thigh. But as far as like neonates, it is up to umbilicus. But like if at all, sometimes actually after giving any surfactant, suddenly actually once the compliance increases, so there the wiggling can suddenly increase and the tidal volumes can increase. So at the time, actually, you have to sit at the bedside and you have to tell the nurse, actually, if the wiggling is more, you need to come down on the amplitude or delta P.
Okay. Yeah. So the next question is the experience with VG with HFOV, and what are the initial volumes you target on HFOV? This is about volume guarantee to Dr. Sunil.
Yeah, we had a full lecture on Sunday regarding volume guarantee, but the thing is like this is an advanced mode of high frequency. So till couple of years back, actually, like most of the ventilators, they don't have that option of VG in high frequency, and some of the ventilators now, like SLE 6000 and Fabian, so they have that and VN 500, they have the volume guarantee, and you have to set the volume around 2 ml per kilo. So for example, you have a 1 kg baby, just 2 ml. So that's what you set. So for example, once the baby's lung condition improves or the compliance improves, then there will be auto weaning. So the amplitude will automatically will reduce. And there is some difference between volume guarantee in conventional ventilation and volume guarantee in high frequency ventilation. In conventional ventilation, actually, your this thing actually, once the volume is reached, the pressure will get weaned off. Whereas in case of high frequency, your amplitude will get weaned off. For example, baby after giving surfactant, if the baby's compliance increases and the baby is getting more tidal volume, then the amplitude will reduce automatically, and there will be auto weaning off.
Thank you, Dr. Sunil. We had an entire session on volume guarantee HFOV yesterday, a couple of days ago. Okay, so again, the next question to Dr. Sunil. How to remove water from tubes? Is there any method without disconnecting the tubes from the lungs? This question is from Dr. Saeed from Dubai.
Okay, I think I should have a circuit here to show that, but usually, like by gravity, it will usually fall down. So you have to just actually make the tubing actually. You have to just vibrate the tube, and you have to allow it to fall by gravity. So and it will fall into the humidifier chamber.
I think if you have a good humidifier.
Pardon?
Yeah. Thank you, Sunil. I think if you have a good humidifier with the heated tubings for both the inspirator as well as expiratory limbs, generally we don't see much problem with the condensation. So the next question is to Dr. Leslie, sir. Can we give feeding on inhaled nitric oxide and HFOV?
Generally, when we reach the inhaled nitric oxide, which means that babies are critically ill, and definitely babies on a lot of inotropes will be there. There's not good practice to feed during that period. If only the high frequency ventilation is there, maybe we can feed the baby. And our practice is sometimes we use a small amount of a feeds, just 1 or 2 ml, to keep the gut intact for a non-nutritive purpose. Otherwise, generally we don't feed when we start nitric oxide.
But is there any strict contraindication to feeds?
There is no contraindication for feeds during nitric oxide, as I mentioned, because as I mentioned, this is a critical ill baby. As a practice that we generally follow, we don't feed a critically ill baby unless the underlying disease state is improved. So only we can follow that, but generally we don't feed during that. Instead of that, we use a partial or complete TPN during that period.
Yes. Maybe if there is a component of hypotension, systemic hypotension, that also will be suffering compromised circulation.
Yes, especially when we're using the other drugs. As I mentioned, this is a good inhaler without systemic hypotension. With other drugs is associated with systemic hypotension. And most of the times we reach the nitric oxide means we must have used dopamine, dobutamine, adrenaline, and sometimes sildenafil or milrinone. All combination will be there. So I feel not a good practice to feed.
The next question is to Dr. Sunil. How to take chest X-ray when the baby is on high frequency oscillation because the baby is moving?
Now, actually, most of the warmers as well as most of the incubators, they have a facility like even if the baby is on conventional ventilation, also you need not touch the baby. So you have a separate slot for that. So in the bassinet or in the bed. So just by actually removing that particular slot, you can open that slot and you can keep the X-ray plate there. So most of the incubators as well as open care systems, they have that option. So that should not be a problem, like taking X-ray while a baby on high frequency, and it won't usually it won't cause problems in X-ray interpretation also.
Yeah, correct. Because most of the warmers, like you said, it has a provision for putting the cassette underneath. So without even touching the baby, X-ray can be done. Definitely. Yeah. The next question is there any problem in keeping the baby prone during high frequency oscillation? So Dr. Sunil?
So actually, prone ventilation is one of the standard mode. Like if you take the ARDS protocol, especially in pediatric and adult age group, so there is like prone ventilation is recommended. So usually neonates who are on high frequency, so it is very like uncommon situation. There is very little literature regarding actually prone ventilation in high frequency neonates. But theoretically it sounds good. So because actually you are opening up the uh, posterior part of the eclectic alveoli also. So prone high frequencies also can be done, and it's easy to make the baby prone as compared to a pediatric age group or adult age group. So but if you go into the evidence, actually very few case series as well as non-randomized trials are there. So I've gone through that evidence. Actually there are no randomized studies to look at this aspect, but whatever the case reports are there as well as this non-randomized trials are there, it has shown that actually it improves the PaO2s as well as it improves the this saturation levels better as compared to supine position or other positions.
Uh,
But,
Can I add, Abhishek, one
yes,
more
sir.
point
Yes,
here?
sir. Yes,
Yeah,
sir. Please.
it's a very good practice, especially, but depends on the nursing staff. We have some of those nursing staff, they are very good. And they immediately, when we know that the whatever required oxygenation is not getting in a high frequency ventilation, they usually keep the baby in a prone, little upright, maybe about a 15 to 30-degree upright, and keep the baby prone. Uh, but here we need to have a nursing staff be their side, always monitoring. It is a good practice, and people are following this. Bigger baby, little difficult, but smaller baby is always easier to pro nursing, and the outcome is also better.
Okay, so thank you. So the one more question. This is on inhaled nitric oxide. Uh, in non-responders, after 1 hour, can we stop inhaled nitric oxide abruptly? By Dr.
Y-
Shweta.
Yeah, yes, I would say yes, but I have already mentioned uh, some babies are very low responders. They take little longer time to respond. And once we connect the nitric oxide, that circuit itself is a disposable circuit, which is about 6,000, which cost, not because of the circuit cost, but some of those babies are slow responder. They might take a little longer time to respond. So even the books mention 1 hour, stop it. But practically, I think we can wait for at least 2 hours to 4 hours. You can go up little higher dose to 40 parts per million. We never gone beyond 40, even though a lot of literature and evidence says that you can go up to 80. We don't go up to that 80. Wait for few minutes, and there is no response. They can de-escalate and then can wean down and stop. So 1 hour is too early in a non-responders. 2 to 4 hours could be the ideal one. And especially if there is infection has set in, sometimes we use a nitric oxide at last stage. There we have a problems, and these babies are not going to respond in the initial phase. So you wait there, and then not responded even for 4 hours, maximum 4 hours. Better stop the inhaled nitric oxide.
So one more doubt I had, like how frequently do we encounter non-responders?
If you have two things, one is oxygen index. if you have initiated nitric oxide very early, somewhere 20 to 25, they respond very well. If you initiated the nitric oxide at a later stage, waited, and then you thought, let's try last resource. Most of the times, by default, what I've seen, the nitric oxide starts at the middle of the night only. And where we know that everything is exhausted, saturation has not picked up, we land up in that situation. And connecting the sometime nitric oxide is also not so easy. Even that's the reason we keep training some of the nursing staff, respiratory therapy, postgraduates, and our postgraduates, so that they are ready to connect in our absence. So one is oxygen index. Second thing is disease state. Disease state, like as I mentioned, pulmonary hypoplasia, secondary due to a CDH, they don't respond at all. In our setup, 2 babies have responded. Possibly there may be a partial pulmonary hypoplasia that could be there responded, and we could able to proceed for surgery and then come out successfully in that babies. And cardiac babies, post-operative phase, pre-operative, there's no point using nitric oxide at all. Post-operative phase, nitric oxide is some babies requires, and some babies, they won't respond at all. So, and if it is a multiple factor, meconium aspiration is there, already infection is there, generally they don't respond at all. So these are the things. So if you have to start early and don't wait longer period.
Okay. So one more question. When can we decrease FiO2 to less 50% during weaning from INO? This is from West Bengal by Dr. Devashish Mohan.
I think different unit have a different protocol. What we start is, I mean, most of the times if you've gone INO means our oxygen FiO2 somewhere 90 plus. So it could be better to come down to 60 or high frequency to a conventional ventilation there. Okay, and then wean down your nitric oxide from 20 parts per million to 10 parts per million, and you wait till 5 parts per million. But don't stop it at 60% oxygen. You bring down the FiO2 to 60% to 50%, and maybe still lower down to a 40%. And then from 5 parts per million to 1 parts per million, you gradually wean down. That 5 to 1 is very, very important. You have to come down very slowly. And that phase also, if you land up with the hypoxia, you go up FiO2 to 20%. Need not to go back to a nitric oxide. You started by 10 and then you come down to 5. You don't go back to a 10. You wait a 5%, increase the oxygen to 20%. That is 40% is there. Go to 60%. Wait for 1 hour or 2 hours. And once the oxygen is improved, bring down the oxygen and then bring down the nitric oxide.
One more question again to Leslie sir. Can we use INO in less than 30 to 32 weeks?
Yeah, the evidence is already, I have mentioned it is less than 34 weeks. 2007 Cochrane review says that it's not going to benefit. And I have put up our incidents also where we had 4 babies with RDS requiring nitric oxide. They didn't do well compared to our term babies. And when FDA has approved this drug, they mention it is clearly beyond 34 weeks of gestation. Recently, 2019, there's one article has come up. During a resuscitation, to reduce the FiO2, you can use the inhaled nitric oxide. I'm not sure how safe to use nitric oxide during resuscitation, and which is one of the journal has published, and they've done the randomized control trial. One arm they use nitric oxide with low FiO2. The second one is only FiO2. Wherever they use nitric oxide with low FiO2, shown better response with the resuscitations. So people are started using it. Maybe we can use, but we have limited experience using less than 32 weeks of.
Again, one more question. When to start adjuvant medicine and what is its use, probably in relation to PPHN by Dr. Selva?
Yeah, I think before we go to a nitric oxide, we have tried with our ventilation. We have confirmed with PPHN, And the moment we know that PPHN is there, the drugs generally we use sildenafil, people use milrinone, and yes, and the inotropes. Inotropes definitely use required because we need to keep the systemic the normal tension. At least the PO the blood pressure should be more than 45 millimeter of mercury. So what we are doing, we use adjuvant like inotropes like a dopamine. Dopamine is generally used in a PPHN situation. But in addition to a dopamine, when this nitric oxide is used, we use milrinone. So because milrinone acts as the phosphodiesterase 3 inhibitor, whereas the nitric oxide inhibits the phosphodiesterase 5. So the assumption could be cyclic GMP and cyclic AMP levels could be higher and leads to a pulmonary vasodilatation. So we can use these two drugs, or we never use nitric oxide along with the sildenafil. In fact, we don't use sildenafil in our unit when nitric oxide is there, and rarely we use the sildenafil. So we don't have an experience of using sildenafil with the nitric oxide. So inotropes definitely you can use, and milrinone you can use, and limited experience with the sildenafil with nitric oxide.
Yes, and also it is important to remember probably that ION is not a replacement for other fundamental strategies like lung expansion,
Yes.
taking care of blood gas, preventing hypoxia or hypercarbia, euglycemia, perfusion. These things have to be optimized. Lung expansion is very, very crucial before starting INO. Probably you already mentioned that in the slides earlier.
Yeah.
And another question, what is the maximum dose we can use INO by Dr. Saroj from Assam?
Yeah, I mentioned the start dose is 20, no response, escalate to 40, go it faster, and there is no response to 40, we don't suggest going further up. If it is not done any justice to 40, unlikely going to that particular baby is not going to respond to beyond 40. Safe dose, as I repeatedly mentioned in the presentation, are 20, but maximum escalation we can do are 40, wait for 1 to 2 hours, or maximum maybe 4 hours, no response, wean down, and maybe you can stop the nitric oxide there. Beyond 40, we don't suggest, because the more nitric oxide you use, it releases more methemoglobin. I mentioned there. 20 parts per million is safer. Maximum 2 to 3 the grams of methemoglobin is released. But more nitric oxide, more methemoglobin, the tissue delivery of oxygen comes down and not going to do any justice.
Do you use do the methemoglobin levels routinely?
Yeah, we use ideally 24 hours, but I think literature shows after 12 hours we can do. The second thing, you need not to do regularly methemoglobin. I mentioned the Massimo pulse oximeter with this SUNIL extraction technology, also called as a rainbow technology. It gives it displays the methemoglobin continuously, but we need a special probe for that. And we can use that special probe and we can continuously monitor the methemoglobin levels. And if we're going beyond 20, it's better to have that methemoglobin continuous monitoring in our unit.
Okay, that comes as an add-on to the routine Massimo pulse oximeter.
Yes,
right?
it comes as an add-on to the routine pulse oximeter. Routine pulse oximeter may be pulse pressure and pulse volume index all might do, but here it is this gives a different one, the methemoglobin estimate, and which is available in the market.
Next question is to Dr. Sunil. How long can we use the ventilator tubings after each use? Each company insists to throw the tubings after each use.
Can you repeat, sir? Can you repeat? How long?
I think the question is, can you repeat? Can you reuse the ventilator tubings?
Yeah, like it can be used. So you need to do ETO sterilization for that. So best thing is to do ETO sterilization. So some people, like if you are using reusable ones, so some of them can be autoclaved, But as you're telling, actually the company recommendation is not to use, but you can use for 2 to 3 babies. So that is not a standard practice. I won't recommend, but if you have a very poor patient and you don't have option, so then you can do INITIATIO sterilization and you can use. So we use very sparingly. So it's not a routine to use. Not a routine to reuse those tubing.
Yeah, correct. Generally, it is not a good idea to reuse tubings. Probably we can do cost cutting on other aspects than reusing the tubings. Yeah. Again, one more question to Leslie, sir. What is their nitric oxide cylinder? Is it only nitrogen or any other thing? By Dr. Girija from Bangalore.
Yes, I think if I go back to my presentation, when they mix the gas, they usually puts there how much nitric oxide is there and how much nitrogen and nitrogen dioxide is there. So generally, it is the 90% or 95% is the nitric oxide, but small amount of nitrogen is available. And it is usually once they do the filling of the gas, they mention how much nitric oxide, how much nitrogen dioxide, and how much nitrogen is available.
What about the medical gas and the industrial gas? Obviously, the company recommendation is to go for the medical gas, which is more expensive. But in some centers, probably they might go for the industrial gas. Which one would you suggest?
What we get is mostly the industrial gas only. It's not the pure medical gas. The pure medical gas nitric oxide is still expensive, and I don't think it's available in the country.
Again, the same question. Can I buy nitric oxide cylinder? We need some license.
I don't know the oxygen. The cylinder people will supply nitric oxide, because for the last 1 decade we are working in Manipal and we have different sources of oxygen coming, and whenever we ask them to whether they can do the filling of the nitric oxide, they say it is not possible. So I don't think it is possible. It has to be sent to the specific the person who can do this filling up. And as I mentioned, the chemics gas is the one person is doing. I think there's a couple of people are there in Bangalore. They do the filling of this nitric oxide.
Okay. And one more question to Leslie, sir. Can I use INO during transport? Do you think I should take so costly medicine? By Dr. Kashinath.
Yes, you can do it. And I think it is doing it in Australia and or developed countries, especially when the meconium baby is transferring, they do nitric oxide, but I think they have a smaller cylinders are available, and the system which is available, which connected to the nitric oxide and the transport ventilator. But presently in Indian scenario, the cost of the nitric oxide monitoring system is 15 lakhs. Plus the cost of maintenance is higher. So I don't suggest maybe a good option at this stage to use the nitric oxide during transfer. Instead of, let us concentrate more basic airway, breathing, circulation, temperature, glucose before we go for this costly equipments.
Have you tried any time, sir, in KMC Manipal using INO for transport for any baby?
No, not possible. Because that mission is a expensive mission and a heavy mission. So unless the low cost equipment, where I think that Dr. Dinakar has got some experience of using low cost equipment, maybe with that can be tried with the nitric oxide cylinder alone for a transport purpose, but not the regular monitoring system which I mentioned in the presentation.
One more question: can INO be given with CPAP?
INO cannot be given with the CPAP because the INO has to be requires the nitrogen dioxide has to be scavenged. If you use to the CPAP, it is exposes to the environment. That's the reason I showed the scavenging system. When nitric oxide has to be used, scavenging system should be there. It is similar to inhaled gases using in the OT, and we don't have an anesthetic and the scavenging system. people will be disoriented. And same thing will happen people who are working in the unit. So as of now, and as of we are aware, we cannot use the nitric oxide through a CPAP system.
One more question from Dr. Ashwish Riyan. Do you face issues with ball pin dropping down on its own with SLA inosis?
Very common it is. And I think if I ask, the SLE we have majority of the time setting in the equipment and sudden drop of that ball pin, and then just wait there, don't do anything. So, and then automatically filling up the gases is very common. But I think that the another machine which I have shown, GeoNox, which has recently started marketing in India, I think that problems may not be there. And the beauty of that machine is it shows how much gas is available and how long it is present, how long we can use it. Like the how much petrol is there in our car and how much distance it come. Well, SLE system, it doesn't show. It suddenly gone means gone it is. Then you have to wait for another cylinder to get in, connect it. By the time it takes another half an hour. But that kind of a problems is not there with the GeoNox system.
And methemoglobin measurement using Massimo versus blood test. What is the difference in the reliability?
Blood test is always gold standard for methemoglobin estimation and more accurate. But if you have a every time and every day's monitoring of methemoglobin is little cumbersome procedure, and if you have the Massimo set technology and then a specific probe for a methemoglobin estimation, definitely we can use this one, and we can avoid using the blood estimate.
One, I think this is the last question to Dr. Sunil. Can we use dual heating limb circuits after ETO?
Yeah, that can be used after ETO. Usually that won't get spoiled. So if you do autoclaving, then the chance of like you can't reuse that. But with ETO, you can reuse that thing. So the both inspiratory as well as expiratory tubing, the dual heating system, you can use that after ETO sterilization, not after autoclaving.
I think this is all the questions that I'm having at present. Anyway, it was a wonderful session. Lot of questions and doubts from the audience. I think there's one more question that has popped up now. Is there any specific reason why you mentioned monitoring post-ductal saturation PaO2 in your presentation? This is from Dr. Vamshi, third student.
Yeah, I think the post-ductal is more reliable than the pre-ductal. Pre-ductal is always, the saturation is always higher. And PPHN situation, we know that most of the time pre-ductal saturation shows 95, and we put the pulse oximeter post-ductal, it is hardly shows 85 or 90. So targeting the post-ductal saturation more than 95 is always better compared to a pre-ductal saturation. Similarly, when we do a blood gases, instead of right hand, if we do a blood gases from post-ductal or the umbilical arteries, if it is available, is always better. So earlier practice was they're using pre-ductal, but I think now we have changed the practice. We prefer post-ductal saturation.
So definitely INO is a magical drug in certain specific conditions, but knowing when to use, when not to use is very, very important. Also, the maintenance cost and biomedical support, these things probably needs to be kept in the mind. Any other questions, Prashant?
Sir, Dinakar sir, have you received any other questions, sir?
No, all the questions. No questions.
I think the entire presentation and the questions, number of questions, almost 15 plus questions. Hello? Yeah, 15 plus questions has covered the entire topic altogether. And
Dr. Leslie?
Yes, Dinakar.
Please. Leslie, one small addition. Yes. Beautiful talk in elaboration. We can see lot of effort is there. Okay. And Sai Sunil Kishore, Sai, as usual, and super. No, I don't want to talk simply like that. People are there. Really nice talk. What we want, what each and everything.